Bismillahirrahmanirrahim. Thank you to invite for this presentation on growth plate injuries in this 10th Pediatric Orthopedic Conference at Lahore. I am Dr. Bhatti, Anisuddin Bhatti from Karachi. So my agenda will be to discuss few things about the growth plate and applied anatomy, growth and remodeling phenomena. Mostly my lecture will be on the Physeal bar, its pathogenesis, evaluation, and management. You all knows this is the hypertrophic zone in the growth plates, which is the most weakest portion in the pediatric bones. Almost all the fractures occurs through these hypertrophic zones, and due to presence of this growth plate, which is the weakest portion, the pediatric fracture has the unique pattern which is not seen in the adults. And we call this Salter and Harris type of fracture of epiphyso-metaphyseal fractures. Physeal growth plate or physeal plate is basically responsible for the longitudinal growth of the hair and the remodeling phenomena after a fracture when occurs in the metaphyso-epiphyseal regions. Through this remodeling phenomena, the bone corrects its shapes, it straightens itself over the time, which is not significantly happen in the children. There is a significant remodeling capacity in children bone that depends on three factors in combination. One is the mechanism of bone remodeling, which we see through the Wolff law. Then reorientation of the physis and the asymmetric growth following a fracture, and the age of the pattern. In combination, the remodeling capacity is established. This is one of the example of the remodeling capacity with the age and orientation of the physis. There is a fracture type 2 in the proximal femur with a gross displacement of the caput in the age of 1 year. And at the 15th year, it is significantly grown up child with significantly normal bone. While if you see in the age of 8 years, proximal humeral fracture, metaphyseal type 2 fractures, the displacement, and over 2 years, there is no significant remodeling as compared to the fracture occurred at the age of 1 year. Growth arrays because of the fractures may lead to the angular deformities and limb length discrepancies. The angular deformities, malrotation, and growth arrest occurs when the physeal fracture surfaces are not reopposed properly, or there is a vascular supply is permanently damaged, maybe because of the trauma type 6 fracture or radiations injuries, and the physeal fracture heal with the callus instead of a primary healing, leading to a formation of osseous bridge that we call Physeal bar between secondary and primary ossification center across the physis. I now concentrate on the Physeal bar. Remaining of the growth disturbances and the deformity correction will be taken by another speaker. This osseous bar bridges across the growth plate. Causes are mostly trauma, as epiphyseal fractures, radiation injury which may lead to the ischemia, or a septic foci or infection in the metaphyseal region. Common sites are knee, ankle, and wrist. Types of this are sometimes it is mostly either complete physeal arrest or incomplete growth problem because of the physeal bar, and the center or peripheral region is the location. It may lead to the angular deformity, growth arrest, or limb length discrepancy. This shows the type 4 metaphyseal fracture, and it produces a linear bar nearly in the center, while type 5 or type 1 fractures, Physeal may produce a growth arrest at the periphery, and type 3 fractures usually leads a central bar formation as seen here. Pathogenesis, if you consider the formation of the triangular bone formation, instead trabecular bone formation, instead primary healing causes premature fusion with a bone bridge between epiphysis and metaphysis across the physis. Among common site, distal radial fracture are more common, but bar formation is relatively rare, whereas distal femoral Physeal fracture are less common as compared to the radius, but bar formation is more common. There is also variation in the type of bar that depends on the physeal anatomy. In distal radius physis, it is two-dimensional and unipolar, while in distal femoral physis, it is three-dimensional and biconcave type of the bar. In differential diagnosis, we may consider a mid-lung deformity of distal radius, a Blount disease in the tibia, and idiopathic limb-length discrepancies are a developmental discrepancies or shortening of the bones or legs, angular deformities related with the epiphyseal dysplasia. We can differentiate these with the conventional radiography, scanograms to assess the limb length discrepancy and angular deformities as we can see in this child. CT scan and MRI. CT scan have a better understanding. It provide information about the localization, extent, and the Physeal bar mapping. This is the Physeal bar mapping. The bar is here. And with this mapping, we can localize where the bar is, and then the surgical intervention can be done easily. This is one of the example of a 10-year age boy. Here a proximal tibia fracture in 2022. Second time he has a distal tibial fractures. In November 2023, he was managed conservatively because displacement was not so gross, but it leads to a significant limb length discrepancy because of the metaphyseal bar, and you can appreciate a genu valgus deformity and ankle deformity distally. Treatment is non-operative when anticipated lower extremity leg length discrepancy is less than 1 centimeter. We have to observe frequently, 3 quarterly in the year. Lower extremity discrepancy 1 to 2 centimeter, then inner sole can be given. When discrepancy is between 2 to 3 centimeter, shoe raise can be given. However, discrepancy more than 3 centimeter and significant deformity, it is better to excise the bar and reconstruct. Physeal bar resection, there are significant indications. Age, location, and size of the bar significantly influence the indication and outcomes. In younger children tends to have a better prognosis. It was indicated by the Langen School in 1981. Surgical resection is indicated in patients with anticipated growth remaining from the affected physis about 2 years. Less than 2 years remaining growth is relative contraindication. And it is also indicated when less than 1/3 and half of the growth period is involved, it gives good results. Central bars are more amenable to resection than peripheral bars. In upper extremity, physeal bar anticipated discrepancy of up to 5 centimeter is indication for surgery, while ischemic and post-septic sequelae bar have a poor prognosis. Surgical options is very important. The meticulous plan and Physeal bar mapping is an important prerequisite. Two methods are there. One is conventional burr and interposition of the graft, and other is the arthroscopic assisted resection. Interposition of fed graft is easiest and most commonly used agent to prevent reformation of osseous graft after resection of with the burr. Alternate agent which can be used is silastic graft, methyl methicillate cement, and free physeal. These two mostly needs another operation to remove it. While arthroscopic assisted resection and grafting is minimal invasive, accurate, and safe, and most commonly used method today. This is the bar resection with burr through a metaphyseal window after localization of the central bar through the CT scan physeal bar mapping. Make a window from here, have a burr resection of the bar till a cartilage appears on the both sides and fed graft inserted. Here, a lateral window is formed for the lateral peripheral bar resection. This is the very important article published by Lengiskold in 1981, and this shows the bone bridge connecting epiphyse to meta was removed and replaced with free fat graft, resulted in restoration of growth, correction or prevention of deformity. Operation prevents the deformation of the joint surfaces, an effect that cannot be achieved by osteotomy or leg lengthenings. He used free fed graft and as an interposition of material. That is, he said, there is some indication advantage compared to the solid material which require a second surgery for removal. This is type of arthroscopic resection which is mini invasive, more accurate, more safe, and fast recovery. It is the window is performed here and the closed osteocavity is prepared. Fluid irrigation produces a stable fluid pressure, which stops bleeding and gives clear vein, and physeal bar resection under all inside visualization. This is the technique of arthroscopic resection. Step 1 is placement of the K-wire to localize an orientation of the tunnel to reach the central bar. Then along the on the K-wire, a tunnel is created, which is 2.5 centimeter side length, and close the skins with the towel clips to create a pressure inside to form a closed osteo cavity. Then remove the physeal bar under all inside visualization of the arthroscope. Then after that, you can place the grafts or the cartilage. Here is the example of that. The metaphyseal triangular window was created on the K-wire with the pre-drilled screw. Then established a tunnel from here to designated tunnel orientation. Then bar is removed until the cartilage is seen or encountered, and this dotted line indicates the cartilage surfaces are seen easily. Bony bar was then irrigated and physeal cartilage ring was placed. This is the study of the Zhao in the Frontier Paediatric 2023. They conclude using the clamps to close the closed osteocavity could make physeal bar resection under all inside arthroscope visualization feasible, which is minimally invasive, accurate, and safe. This operated 10 joints with the 2 years follow-up. It has improved the average angular angle of the 8.3 degree angular deformity. One had worsening continued angular deformity. All had the significant limb length discrepancy improvement, while the 4 patients still had limb discrepancy, and maybe they will become good after 2 years. There is another paper on the excision of distal femoral physeal bar and distal tibial physeal bar followed to the maturity. They conclude the physeal bar excision to restore growth when applied to an appropriate patient is a useful, rewarding procedure, reducing number of surgical limb length equalizing procedures. It is a demanding surgical technique. It requires a diligent, careful follow-up till maturity. Additional limb length equalizing surgery is frequently required. Thank you for your patience. This lecture will be available on my YouTube, and this is my contact Thank you very much.